It has to do with them. It has to do with their ability to understand who they are, and they don't. They have taken on illness behavior. They have secondary gains. They have other things going on. Give them the questionnaires. Give them the papers. Document it. It'll support your opinions. It'll protect you, right? Next, always ask people about their pain. Now, it's very important, very important. A couple issues here. One, I always ask on my questionnaires to give me a number between 0 and 100, right? Now, there's multiple issues here. One, questionnaires, they usually have the VAS scale. That's where you have a line, you make a mark in line. But the problem with the VAS scales is, first of all, people make Xerox copies of Xerox copies, so those things are always getting weighted and changing over time. Two, you got to spend time measuring things. Three, they tend not to be as reliable of an indicator of someone's responses, especially over time, right? Whereas when you ask people to write a number, it's better. Number two, always ask people to rate their pain between 0 and 100. Why? Well, it turns out that if you give people a scale of 1 to 10, right, then as you're treating them or evaluating them or hoping to get them back to work, something like that, and the numbers start going down, what they experience is that there's a loss of their illness. There's a loss of their identity. There's a loss of their ability to be the patient, to be taken care of, to be impaired and hopefully get more money. So they hang on to stuff. By the way, this is also true. I was a lecturer for the National Institute of Health on smoking cessation. It's also true in the smoking literature. Whereas, the people say, well, you got to quit cold turkey. Why do they say that? One of the reasons they say that is because what happens is if you try to cut down and you get down to 1 or 2 cigarettes, those individual cigarettes take on so much value that it's harder for people to let it go, right? And so that's one of the problems with cutting down or doing these numbers. But, so if you have somebody that says, well, my pain is 90, right? You say, well, I'm treating you, how much better are you? Well, I'm 40, right? Because they feel they got a lot of points left. If you give them 1 to 10 and they go 9 and they're down to 4, all of a sudden that 4 seems like it's getting pretty near the end, right? But for you and I, it's the same result, right? We've got about 50% improvement, right? Give them the questionnaire, but give them this. Now, look, here's CNA, the woman that was bench pressing the residents. Your pain right now. By the way, in my questionnaires, it says pain 100 means you have to be hospitalized. These are people who sit in my exam room, people sit in my waiting room, people sit in my office taking the history, put down hundreds, right? Give them a questionnaire. Let it get documented so you know what you're dealing with, right? Look at this one. This is a patient, 47-year-old, who said cleaning cameras hurt his arm. Now look at this. Your typical average pain, severe 100. Severe 100. Oh, it's not enough to say 100. It's not enough to say I need to be hospitalized right now. It's like 100.9. That's all you're going to give me, right? I can give this guy a scale 1 to 1,000. You pick 1,000, right? This is someone who cleaned cameras and it hurt his arms a little. Are you kidding, right? You're going to say that, oh, this person needs a tubular tunnel release. This person needs a carpal tunnel release. Oh, this person's, are you kidding? You're nuts. Don't touch these people, right? They are having a problem. They are seeing themselves in a certain way. This is their limitation, right? You are seeing somebody that have taken on illness behavior, chronicity of illness, delayed recovery, right? They are not going to get better in their current mindset, right? Okay, next. As you remember, we talked at the front end about the biopsychosocial model, okay? So depression, anxiety, that'll do it, right? If somebody's depressed, if somebody's anxious, they're going to have all this symptom reporting, right? And by the way, look. These are only 2 questions. And the reason I did that is because there's a lot of literature. Look at all the literature I put in here for you guys. Look at all this literature that you can usually ask 2 questions, right? And get about as much discrimination as you need, right? I'm not saying that all these questions, the Becks and all these other big ones, are nothing, right? Okay, that's more in the psychiatric world. But for you and me, trying to get a quick picture, what's operating, what's in somebody's head, right? What's making them tick, right? Ask a couple questions on anxiety and depression. And if they're anxious and depressed, you're going to know what's operating, right? And there's ways that you can look at these questionnaires. that lets you know that there's literature that supports. Just give them 2 questions. Now somebody say, well, I see in here that you gave him a questionnaire. You only asked 2 questions about depression. Doctor, are you saying my page is not based on 2 questions? You say, hey, look, I'm not a psychiatrist. I'm not a psychologist. What I'm saying is that it seems like some of these things are operating, which is why, in my professional opinion, I offered the impairment rating and the recommendations for treatment based on all the information here. If the parties want a more definitive answer on this area, then you're welcome to consider colleagues in that field, right? But what it does for you, it protects you. It gets documentation. It lets you see what you're dealing with. It lets you know not to treat these people the same way, right? When I see these things, I don't treat them the same way, right? We know that depression can present as pain, and pain leads to work loss. We know that the sickness preemptive working while being sick can lead to depression. We note that 69% of depressed patients present with somatic symptoms. 47% of the general anxiety disorder patients present with somatic symptoms. They don't come in and say necessarily, I'm depressed. They don't come in necessarily and say, I'm anxious. They come in and say, my back hurts, my shoulder hurts, right? You have to know it's operating. And it's important. This stuff leads to divorce, work loss, suicide, bad things, right? So give them a questionnaire, document it, protect yourself, have that documentation, right? Next, health locus of control, okay? This is a very important concept, okay? This has to do with self-efficacy. Okay, in health locus of control, there are 2 types of people, internals and externals, okay? An internal, right, is the kind of person that's an ideal patient for you and me. These are the kind of people that say, you know, oh yeah, give that to me, I'll take care of it, I understand, I'm on it, right? You say to people, I want you to go see the neurologist, get this MRI, start the physical therapy, come back in 2 weeks. And they're on the phone, on the door. I got it, I'm doing it, I'm gonna make myself better, I'm gonna do this. And they come back and say, look, I did this, I exercised myself anyways, and I'm better anyways, right? And so this has an internal locus of control with social support, with the way that they're wired, that they can do well. That's an internal, that's an ideal patient, right? Externals see the world very differently. Externals say, I am not responsible for my health. You are responsible for my health. As a matter of fact, you, the employer, you, the doctor who's examining on behalf of the employer, you should have known better that this job was going to create troubles. You should have known that this injury could happen. You are the one that should be helping me out with this. And by the way, these are the people that will come into your office and say, look, you asked me to take this medicine, didn't do much. You asked me to go for here, didn't do much. The only thing that's helped me is going to the chiropractor or going to the acupuncturist. And you only have me going twice a week or 3 times a week. I want to go 5 times a week. Okay? All right, so what's going on there, right? Multiple things. One, we already know that if they're an external, they don't want to do anything, right? So the chiropractor, a bad chiropractor, is a dream for this, because the chiropractor keeps saying, well, I am the way, I am the way, you know, the light, I am the Lord, you know, just keep coming back to me and I'll keep taking care of you, right? So people like to be taken care of, right? But what are the principles of physical therapy and rehab? We know those principles, right? Posture position, flexibility, aerobic conditioning, and muscle strengthening. Those are the principles that keep people better. There's no question that when a chiropractor moves you, it can feel better. The question is, who's supposed to be moving you? The chiropractor for the rest of your life, or you for yourself, right? And another thing is, there's no question that when you have a chiropractic thing or massage or ultrasound or electrical stimulation or acupuncture, you get an endorphin release. And yeah, it makes you sleepy, it makes you feel better for an hour or 2, right? It doesn't last because you haven't addressed the underlying area. But externals will see this and they'll say, look, this is really going to be a problem unless I continue to get this kind of treatment, right? But the problem's not in their spine. The problem's in their mind, right? The problem is how they're viewing themselves, right? Here's one. Look at this. Look, here's their CNA, right? extremely anxious, extremely depressed. I have no powers, right? Right? This is the patterns, right? You're going to see, right? Another one, look at this, fear, avoidance, belief. Now, Gordon Waddell, who I had the pleasure of knowing, and he wrote one of these questionnaires, the fear, avoidance, belief questionnaire. I took the most discriminating question from his questionnaire, right? And I said, what happens when they say that they have fear, avoidance, belief? They believe that any pain equals injury. Any pain, right, does not lead to anything but trouble. They've never heard no pain, no gain, right? But we all know that's not true. We all know that from an injury, especially surgery, that there's rehabilitation you have to do. You have to strengthen yourself. You have to build yourself back up. You have to improve yourself. We already know that, right? We already know that that's operating, right? So if somebody has high fear, avoidance, belief, right, they're not going to get better. They're not going to participate in their care. They're going to want to go to the passive modalities. They're going to want to lie on tables. They're not going to want to work. But that's not in their best health interest. That's not in healing them, right? Give them a questionnaire. Ask them the question. Which, by the way, I've had this before, where I've given these questionnaires, and I've had people on this stuff where they say, "Hey, you know what? I actually have these high fear beliefs and all this stuff." So, I had somebody come in. Ready for this? Ready. So this woman comes in, and puts these records on my desk, and says, "Dr. Hyman, I've seen these other doctors, and I have a problem, but I referred to you, and I heard that you're a very good doctor, and I'd like to work with you and try to help this out, and all that kind of stuff. So I want you to see, though, I take this seriously. I've been to 5 different doctors, and I've done all these tests, but I don't want to talk about them because I'm not sure that they're really doctors. But I can tell you are different. I like you. I like your office. I like your staff. It's very good, very helpful, right? And so what I'd like to do is I'd like to get to the bottom of this, right? And I'd say, so, sorry, wait, what's going on here, right? And I said to her, well, can I look at some of the records? No, because I don't think they do a very good job, right? But I can see you're a good doctor. I think you could do a good job, right? And then I say, well, okay, what were some of the diagnoses, some of the treatment stuff? Well, they said this, but nothing else, nothing gets better. I don't think that they're right. I don't think they've done a thorough job. Now, it turned out that I got out a little bit about some of the doctors she'd seen who I thought were good docs, right? And so all of a sudden, I get those little hairs raising on the back of my neck, right? And I start getting nervous, right? Because this is going to be somebody that's going to have something's going on there, right? So it turns out this woman was a writer. So I said, listen, by the way, I want to ask you in your profession, right? Since you're saying that medicine hasn't been able to help you, in your profession, I've heard that there's this thing called writer's block, right? Where you're working on something and you're trying to write, but you can't quite get past it and you have to do something. And says, that ever happened to you? She goes, no, never happened. Because what you can do with the writer's block is you can actually go get a consultation and identify the script and do this, right? And so, and I don't really want to talk about that. What I want to talk about is whether you're going to be helping, because clearly these other people didn't help me, right? And so what I'm trying to get at is I'm not happy with the care I got and some of that. So all of a sudden you start hearing that, right? So everybody is good or bad. You're with me or you're against me, right? When you start seeing that, right? That is somebody that's starting to display borderline personality disorder. At minimum, borderline traits, right? They see the world as good and bad, yes and no. You're with me, you're against me. And one of their biggest manifestations is anger. They're angry at the doctor, they're angry at the employer, they're angry at the injury, they're angry at everything. If you have one of these types of patients, right, a borderline that sees the world this way, what is the treatment of choice for a borderline? It is probably to get them out of your office, right? And you're going to say, oh my God, that's cruel, Mark. You're a doctor. You're supposed to help people. Treat them, okay? The borderlines may not see your efforts that you're trying to treat them. And unless you're about to tell me that you're an expert in handling borderline personality traits and disorders, I'm telling you, it is going to be fraught with difficulties. You're going to try to apply your same standards. You're going to try to use the same MRI, the same physical exam, it's not going to work. Eventually, they're going to blow up because you're going to give some recommendation which seems reasonable based on the literature, and they're going to latch onto it and say that you did not treat them properly, right? By the way, don't think that I'm being a bad doctor about this, right? Don't think that, because I've had some of these patients and I've tried to refer them to my colleagues for help, my psychiatry colleagues, psychology. I said, oh, Mark, I don't do borderlines. What the heck does that mean? I'm asking you to do them. I'm asking you to treat them, right? I mean, oh, no, I don't do borderlines, right? Because they know how difficult they are to treat, how difficult they are to try to get them to follow a program, to stay within visits, to not call them excessively, to not put blame on them for everything that goes on, right? I've had this happen to me before, right? You first meet a patient, you think like, oh, I really like this person. They got a good personality. We really click, really connect. And then all of a sudden, one day, go south. You're like, what happened there, right? Those are the borderlines, right? These are the people that you can pick up from some of these questionnaires. You got to know about it. Give them a questionnaire, document it, protect yourself, right? Next, job satisfaction. So, doesn't come as a big surprise. If somebody doesn't like their job, they're not going back, right? Give them a questionnaire. So these are the Vermont and APGAR scales. So once again, I took what I thought were the most discriminating questions from the Vermont and APGAR scales and put them together on a questionnaire, right? You know, how much you like your job, how well you get along with fellow employees, and how certain are you going to be back to work within a few months, right? And so what you can do is give them these questionnaires. What are they thinking, right? Take a look. Look at this. Look at this. Please indicate, oh, I love my job. I love my job. I'm not going back. You see this? You see this? Love my job. Love my job. I'm not going back, right? Give them a questionnaire, right? It's very important, because if you give them the questionnaire, right, they're going to tell you what's really operating there. By the way, I've seen this a lot of times. I've had patients who not even circled zero. They circled not at all certain. They're not even on the page, right? They're not even in the scale, right? They're telling you it's not the mechanism of injury. It doesn't matter what the MRI shows. It doesn't matter what the nerve conduction study shows. It doesn't matter who you are. It doesn't matter who you train with. It doesn't matter anything, right? What matters is who they are, how they're perceiving themselves, and what's really going to operate. And you think that you're going to get these people back to work? You think that doing surgery, you're going to improve them? No chance. That's not where their head's at, right? It's not in their spine, it's in their mind, right? I've had, by the way, this is a true story. I'm going to tell you the story. True story, right? I had a woman that got sent to me with a shoulder injury. She worked at a hotel here in Los Angeles, big hotel. And the human resources person knew me, sent her to me, said, well, you know, she's been in treatment for a few months at this, you know, doc in the box thing, and she's not getting better. Could you take a look at her? So I said, sure. You know, I evaluated, gave her my questionnaires, right? So on this question, she circled a 0. And on her history exam, you know, she'd been cleaning rooms, just housekeeping. So, okay, you can get some shoulder difficulties, but doesn't seem too bad. Her exam wasn't too bad. And I said, well, you know, I don't understand why you don't think you're going to go back to work. She says, well, I don't know. I'm just not sure how my shoulder's going to do. I said, well, okay, you know, I think your shoulder will do fine, but we'll get you in physical therapy. We'll watch it carefully. I called the human resource person. Now, listen to me.